Hello, everyone. Welcome to our rounds today. Today we have Dr. Gary Block. He is a family physician in Toronto with St. Mike's Hospital and Inner City Health Associates. He is also an associate professor at the University of Toronto. His clinical, education, and program development, research, and advocacy interests focus on the intersection between social risks to health and frontline healthcare. He has led the development of internationally recognized clinical tools and the development of clinical programs and educational curricula. He serves as his family health team physician lead on social interventions and equity. He is a co-founder of Inner City Health Associates and the advocacy group of health providers against poverty. He also has been quoted by Dr. Gabor Mate, and he's got a couple of teenage kids. Welcome.
Thanks, Kathy. And hi, everyone. It's great to be here. I will just share my screen. There it is. Right. Okay, there we go. You should be seeing my screen right now. Whoops. All right. Yeah, so thanks so much for inviting me here. So I am going to spend the next hour or so really talking about what, as Kathy pointed out, is really my passion, which is thinking about how we deal with social risks to our patients' health on the front lines of healthcare. This is work that I've been doing really since I started practice, which is, about 20 years now. It is always interesting, always dynamic, always kind of mind expanding work. So it's still a lot of fun to talk about. I should say that, I'm very happy to be interrupted, to fall into conversation, to be challenged on things that I am bringing forward. I don't need to get through anything in particular. I certainly have plenty to talk about, but I'm always happy to kind of divert into conversation and just thinking about the stuff that I'm pulling forward because, there really are very few right answers in this area, and there's just a lot of kind of creative thinking and just innovative program development and pushing out of boundaries in this. So that's what I really would love people to engage with more than anything. So to start out, really three objectives for today. First of all, going to briefly look at an argument for why I think we should be doing this work on the front lines of care, why we should be intervening in poverty and other social risks to health, and then really jumping into the interventions. So really thinking about what we can do on the front lines of health to intervene into these social issues at an individual level, and then touching on what we've done as a health team, and just briefly on sort of advocacy level interventions, but we won't have much time to get into that. I should say that in terms of conflict of interest or disclosure, I have received some funding for this work, nothing from corporate interests. I don't think there's any real conflicts of interest in terms of who I've received funding from or how they relate to this talk. And I have received personal financial support for some of the work that I'm doing as well, which has been nice to have because it takes a lot of time. So again, no real conflicts identified. So I like to start with this quote. This is from Rudolf Virchow, who many people probably recognize this name. He's seen as really from the mid-19th century, seen as one of kind of the founders of public health and pathology, and also of social health and social medicine. And way back then, going back close to 200 years, he said this, that if medicine is to fulfill her great task, then she must enter the political and social life. Do we not always find the diseases of the populace traceable to defects in society? And I like this to put this up largely to remind myself that this is a conversation that goes way back. right? That this is not new territory to explore. This issue of the impact of people's context, people's social lives on their health is something that really has been grappled with by the healthcare community for many hundreds of years and maybe thousands of years, actually, if you look back in the literature. So I often point to kind of two big drivers for myself in doing this work. And this may seem somewhat self-evident, but I think they're really important to kind of remind ourselves of just the sort of power and the force that underlies certainly my motivation, hopefully others' motivation to engage with social risks to health. So those two drivers are stories and evidence. Um, and in terms of stories, I mean, as primary care providers, we're obviously immersed in people's stories all day, every day, right? But there are some stories that just really stick with me, and really make me question what it is that I do and whether there's more that I can do to really address my patient's health. So just an example, I mean, this is not him, obviously, but this is representative of a man I met several years ago now in my clinic in a homeless shelter in downtown Toronto. He was a middle-aged man of Middle Eastern origin. He came in with an interpreter. He did not speak enough English to converse directly. And he'd actually just been discharged from a several months stay in an acute care hospital after a motor vehicle accident. And in looking at him initially, I mean, he looked pretty good. He looked a bit like this guy here, but it was pretty evident quite quickly that he'd suffered significant impacts from this accident, and especially cognitive changes, memory changes, and he knew it, right? He kept pointing to his head and saying, "It doesn't feel right. It doesn't feel right." Now, I can also say that, I mean, from the moment he walked into my kind of closet-sized office in the shelter, it was pretty clear that he was wondering why he was there, right? I mean, he did not feel that this was an appropriate space for his care, and he, like me, thought that, having suffered in the way that he had from this accident, he really should be seeing someone other than a family doctor in a closet in a basement. Um, he was someone without income, without official status in Canada, obviously without housing, and with no social supports here. And I can tell you that, when someone like this walks into my office, like my medical mind very quickly jumps into action, right? And normally I'd like to do all the things that I'm trained to do, right? Like, a full cognitive assessment, a full neurological workup, bringing into place the complete rehabilitation team to support him through his recovery, getting his family together to make sure that all the proper backups and supports are available. But in a case like his, my priority list actually looks very different, right? And really, for him, my priorities looked more like, first of all, working to secure him some sort of steady source of income so that he could actually survive day to day through the next few months, trying to find him proper supportive housing that was appropriate to his situation, working with him and his lawyers on his immigration status, so that he could actually access services here in Canada, working with him to deal with the huge hospital bills that he was facing, again with his lawyers, that he would never be able to pay. And then somewhere down at the bottom of that list was trying to help him stay medically stable enough to survive through all of this process. So, it's cases like his, and unfortunately, I mean, these are the cases that I see on a daily basis, and stories that I hear on a daily basis. I'm sure not dissimilar to stories that you all hear on a daily basis. It's situations like these that really lead me to wonder what other skills I can build, what other knowledge I need to deal with the health issues of people who are facing this level of social risk to their health. The other big driver for me is the evidence, right? And I'm not going to spend much time really on this because I think that by now, especially given what we learned during COVID, we've probably all been exposed to the massive body of evidence that links poverty and other social risks to health and elements of social deprivation to poor health outcomes. But what I will say is that living at low income, especially, has been looked at in every chronic illness, acute illness, accidents, trauma. It's been looked at over time. It's been looked at in pretty much every geographical setting you could imagine. It all points in one direction, right? I mean, living at low income, living in poverty is bad for our health and often very bad for our health. We know this is especially impactful on children. I just have to mention this, but growing up in situations of social deprivation affects children from their time in the womb all the way through childhood, and is actually something that adults who grew up in poverty don't overcome, even if they if they change their socioeconomic status later on. So there really is a drive to intervene and to intervene early. Now, I throw up this slide, which kind of shows the same thing I've been saying, but there's a particular reason I want to show this to you. This is Ontario-based data. It breaks down the prevalence of common illnesses that we deal with in frontline care by income quintile. So lowest income on your left in blue, highest income on your right in yellow. And what we see here is this unbelievable gradient right through the income spectrum in terms of the prevalence of these conditions. And I put this up because I'm often asked this question, right? Which is, where is the health poverty line? Meaning, at what level of income can we stop caring about someone's income situation or their social situation as a factor in their health? And I think the kind of data I'm showing here points to the reality that we can never stop caring about this, right? Income and other social realities are always relevant to our patients' health. And then I also want to say that this is not just a story of absolute deprivation that we're talking about. It is also a story of inequality. And I think this is really important to bring out of the literature, because we know from the data, and this is data that's been developed over decades, that the level of inequality, social inequality in a society in itself impacts the health of everyone in that society. And this is a study that came out a few years ago now, but which sort of estimated the number of premature deaths associated with the level of income inequality that we experience in Canada. And by their estimate, about 40,000 premature deaths per year could be attributed to our level of income inequality, right? We are sadly not among the most equal countries in the world. We're a lot closer to our friends down south than we are to other countries that are doing much better on this front. And I have to say, of course, that poverty and other elements of social deprivation do not impact everyone equally. There are particular groups in our society that are particularly heavily impacted by poverty. Again, probably no surprise to any of you, but these include new immigrants, refugees, people who are racialized, seniors, especially when they're alone, children, especially when they have one lone parent, people who are Indigenous, amongst others. So always, again, need to keep this framing in our minds. And I think what maybe helps us to understand this framing is to think about I'm going to show you a representation of what we call the social determinants of health, right? And this is something that was developed by a Toronto family doctor, Nanki Rai, who in this instance represented what we think of as kind of traditional social determinants of health as branches on a tree. And the fruit of those branches are the health outcomes that are associated with those. I mean, that's pretty straightforward, fits with what I've said. But what's important about her graphic is that this tree has roots. And these roots are what we often call the structural determinants of health. So the deeper kind of inbred social and forces that are built into the structures of our society, even built into ourselves, that through their actions actually determine who is most impacted by those social determinants represented on the branches, right? And these are things like racism and colonialism and sexism and homophobia, etc. So again, I want to keep this type of model in mind as we move forward into thinking about the interventions, about what we can actually do about these issues. So this is the last slide I want to show you in terms of background, but it's actually comes out of the Canadian Medical Association, where, I mean, again, they're just estimating the impact of different factors on our health. By their estimate, about 50% of our health is determined by the social conditions in which we live, and only about 25% is determined by our ability to access decent health care. But why I like to put this up here is that it's a bit of a reminder of what it is that I'm really advocating that we do, which is really about expanding that turquoise area, the healthcare area, into the red, right? So expanding our ability to actually impact health as health providers beyond that 25%. Hopefully that's what we're able to do. But I think it's a nice little just visual reminder of where we're going in terms of this work. So this is where I want to jump into the interventions, which is really what we're here to talk about. But I'll just pause and just see if there's any questions or thoughts at this point from anyone who's here. Feel free to unmute and say anything. You can challenge it. You can tell me I'm ridiculous. Nope. Okay. Again, just feel free to break in with anything or throw questions in the chat, which hopefully I will see at any point if you have any questions or thoughts. All right. Let's jump into interventions. So again, I mean, I've been doing this for quite a while, right? And I can tell you that when I really jumped into thinking about this work, the landscape of social interventions in primary care looked a bit like this, right? There was like an idea or two sticking out there in the landscape, not a lot going on in thinking about this. And I can tell you that over the last, I'd say 5 to 6 years, we've evolved into a landscape that looks a lot more like this, which is that there are a lot of things being tried, right? There's a whole forest of trees now of different interventions and different ideas popping up, which is amazing, right? I mean, this is really exciting territory to be involved in. The challenge here, of course, is to figure out, which of these trees are actually worthwhile. And, not to overplay it, but not to lose sight of the forest for the trees. But it's really, again, just fun, dynamic territory to be engaged in. Why there's been such a focus here. I mean, part of this is COVID, but I think the shift here actually predates COVID. And I think is associated just with a heightened focus on social issues and equity in society and in healthcare specifically over the last number of years. So I did a review of these interventions. This goes back a couple of years now, and this was based on actually pre-COVID, a pre-COVID scan of the literature. But at that point, I mean, there already was a fair bit to look at, and I'm sure there'd be a lot more to look at now. And if I was going to sort of break these interventions down into just really broad buckets, based on what I saw in the literature, it would look something like this, that there's a lot focused on the idea of collecting social data. There's some stuff focused on interventions targeting individuals, a little less, but some focused on interventions for communities, and then a really interesting piece of work around what I've called equity-oriented practice change, which is really about kind of looking at our practices critically and thinking about how we can adjust the shape of those practices to take equity-focused issues into account. I will also say that underlying all of this is an ongoing conversation about our role as health providers in advocating for bigger level systemic and structural change, right? Which I think, as many of you imagine, is really where the big impact is going to come when it comes to dealing with social risks to health. But that's not to say that we should in any way avoid taking action on the front lines, because that advocacy work takes a long time and it's extremely unpredictable. So I want to spend the next little bit sort of looking at the individual level intervention. And that's because I think that is probably what's most familiar to most of us, right? Is sort of, and probably what sort of tears at our minds the most is thinking about, what can I do for the individual patient, the person who's sitting in front of me right now in the context of my typical, like, whatever it is, 10 to 15 minute primary care appointment. So I want to offer you a tool, and I'll show it to you in a moment, but this is called the clinical tool on poverty. It's something that offers a very simple approach to dealing with a social risk to health, in this case, poverty, on the front lines of care. And we're going to do this through a case study. This is Carlos. So Carlos is 52. He was diagnosed with diabetes about 6 months ago, and he is quite a recent addition to our team. So we're really just kind of getting to know him and his story and starting to work with his health situation. So with his diabetes diagnosis, I mean, to make a long story short, he did everything he was supposed to do. He went to his education sessions, he took all the medications we prescribed him. He really followed the plan as we laid it out. But I gotta say that, his treatment really hasn't budged his numbers much, right? So despite all of that, his hemoglobin A1C has moved from just over 10 to just under 10, right? So this is pretty disappointing, as I'm sure you can imagine. And this is the kind of thing that leads me to wonder, what am I missing in approaching someone like Carlos's care? And so this is where I want to really kind of expand my approach and my thinking, and where I pull out the clinical tool on poverty. So like I said, what this tool offers is a simple 3-step approach to addressing poverty. And I'm going to show you how this plays out for Carlos. So the 3 steps are really screening, taking into account the risk that poverty poses to health, and then intervening. And we'll go through each of these quite quickly. So this first step, again, is really about asking people about their income, right? And about their social situations in general. And this sounds really simple. And in some ways it is really simple, but I will suggest that this in many ways is the most foundational step that you can take towards actually starting to intervene in social risks to health. Because until we know what it is that our patients are living with, what their situations are, there really isn't anything we can do about them. So we've got to kind of open the curtains on what their social situations are. Now, there are many ways to do this, right? So the tool offers a simple 1-question screener on poverty, which is this: do you ever have difficulty making ends meet at the end of the month? It's been tested and validated in a Canadian setting, found to be very sensitive for identifying people living below the poverty line, and specific enough for our purposes. So, and this is one way to do it. And it's very easy. It's very simple. I will say, I think, like any screening question, that it is just the start of a conversation. So if you generate a positive answer from this, you're really then being pushed to explore these areas further. And I will tell you that more and more what I am advocating is to take a kind of more open, more story-based approach to really working to understand what people's social situations are. And I know that may sound like a big ask. And I don't think it's something that everyone can be expected to do, especially in busy primary care practice. But I will suggest to you that if you want to see a real transformation in terms of how you approach people who are living with social marginalization, social deprivation, you really are going to at some point need to take the time to just sit and listen to their stories. And I'm not the only one who says this. I mean, this is a quote from a wonderful pediatrician in New York, Dr. Sayantani Dasgupta, who says that stories are not the end goal. They're not a treasure we dig up. They're not a simple repository of facts, but rather they're a process. And listening to them is an act of social justice. So we will all sit on a spectrum somewhere between the single question and the ability to really sit with people's stories. But I just want to keep in mind the power of opening ourselves up to understanding really how our patients are living. So we asked Carlos, tell us a bit more about your life and your social situation, right? And it turns out that he's working part-time as a laborer, earning $14,000 a year, right? So he's earning below any conception of a poverty line in Canada, right? This is very, very low income. We dig further though, and it turns out that he is living in a one-bedroom apartment with two young daughters as a single father, paying about $800 a month in rent. So, I mean, you can do the math there in terms of how much money he actually has to live off of every month and his children have to live off of. So they are in deep, deep, deep poverty, right? And this may give us a bit more of a sense of why we're having so much difficulty dealing with his diabetes, right? You can imagine as well as I can all the ramifications of living at this level of social deprivation, the stress, the inability to access food, et cetera, and how that might impact his health situation. All right. So to move to the second step of the tool, this is maybe the most esoteric step, but it really, all it's asking is that we start to link that powerful body of evidence that links poverty with poor health outcomes to our assessments of risk and to the way we approach our patients' health and health interventions. And to explain what this means, I mean, this is a very simple analogy, maybe self-evident, but I think it's important to kind of twist our minds around this, that if we know that someone smokes, does that change the way we approach our screening and diagnostic decision making? Right? And this is a rhetorical question. I mean, obviously it does, profoundly. Right. And so what I suggest here is knowing that someone is living in poverty should really similarly affect our decision making, right? Because I know that living in poverty is as big a risk factor for heart disease, for example, as having high cholesterol, as smoking, as having high blood pressure, right? The evidence is very solid on that. It's not in the guidelines, or not in most of the guidelines, and why that is a topic for another day. But I think it really falls back on us as frontline providers to be making these links for our patients in terms of how we assess their particular health risk. I said it's not in the guidelines. Luckily, just in the last year, there was a publication finally around preventive care recommendations to promote health equity. This is a Canadian review of literature led by another family doctor, my department actually, Nav Persad. So we're starting to see the kind, and I highly recommend you take a look at this this piece of work, but we're hopefully starting to see the infiltration of that evidence into the guidelines for frontline care, but there should be a hell of a lot more than we have seen so far. All right. The third step is the one that everyone I think is waiting for and gets excited about. And this is really the step that says that we can do something to impact on the social situations of our patients. And so we're talking about interventions, and we're talking about interventions specifically here with individual patients, again, not at the kind of social policy, advocacy, systemic level, but there really are things that we can do to change our patient's income situation. And what the tool offers is really a set of questions, right? And a set of questions to ask patients based on their particular demographic profile. Some of them may be surprising, right? Like the fact that I suggest that you ask everyone if they filled out and sent in their income tax forms, right? But I'm going to show you in a second the kind of impact that this can have. I mean, if there's one thing you remember as a gateway into the income security system, it's this, right? It is fill out your tax forms as a person living at low income. The rest of the questions on the tool are, again, really targeted towards people from particular demographic groups and geared towards helping them access some of the high yield income support programs that are available to them provincially and federally. The income security system is vast and complex. We do not need to understand the totality of that system, but I think it really helps to understand just enough to make sure our patients are accessing the high yield programs. So we do this with Carlos, right? So we simply ask him, have you filled out and mailed in your income tax forms, right? And it turns out that he hasn't, right? Not for several years, actually, right? Because he figured, I mean, he's way too low income to pay any taxes. He doesn't have any time to think about this. So why bother with this? And this is something I hear often from my patients. And so I refer them over to a community income tax support service, of which there are services all over the province and the country. They're all listed on the Canada Revenue Agency website. And they help him to file his taxes, right? And it turns out that he qualifies for over $21,000 a year in extra income just through that process of filling out the income tax form and all of the different credits and benefits that he qualifies for through that. Right? So, I mean, this is a 150% increase in Carlos's income, right? And this in itself brings him and his children pretty much up to, or maybe just above, the poverty line for a family of his size. Right? So I will suggest to you that this intervention in itself will have a far bigger impact on his health and the health of his kids than anything else we tried to do to help him deal with his diabetes or his other health issues.
Sorry to interrupt, but there is a question.
Absolutely. So let me open the chat.
Yes.
Yeah, so good question. So would that happen automatically with filing the taxes, or is there additional paperwork that would need to be done? So these benefits are basically automatic. I mean, there are parts of the tax form that are triggered in certain situations. I mean, the most obvious one here is the child benefit, but that child benefit form is part of the income tax package. So it should be filled out by anyone with children as part of the process of going through that package. And of course, if if your patient is working with someone who has any familiarity with the income tax system, like at one of these volunteer tax clinics, they will guide them towards the correct parts of the application to fill out. But I mean, even the online programs will guide people very quickly to these programs. So it's a really good question. I mean, of course, there are other benefits, right? That require separate forms. I'm not focusing on that here. That's like another level of understanding and intervention, really important, but I guess a talk for when we have a little more time. Any other questions or follow-up? Okay. So the last part of the tool here that I want to point to, and then this is a nice little segue into the team conversation that we're about to enter into, but that, we're not alone in all this, right? There are a lot of resources out there to support us. And recognizing that we're all really busy, I just want to highlight a couple. So 211, I think, is a fabulous resource in terms of just finding community services, agencies, supports, figuring out who else is out there in your community to help support your patients with their social issues and social risks to health. And the Your Legal Rights website contains a huge amount of very easy to read, easy to access information about income support programs and other social support programs. It's not just about finding legal support. It kind of outlines a whole bunch of issues around how to access those programs and benefits. So really good just to bookmark somewhere. And then this resource, which is a little bit newer, but I love, it's something called the Benefits Wayfinder. It was developed by a national financial security organization called Prosper Canada. And what it does is it guides people through a set of questions. There's not a lot of questions, they're very simple, but sort of guides them through to help determine which income and other social support programs they may be eligible for. And then produces a really easy to access, simple, plain language list and description of those programs and how to access them for people. This is a resource. I mean, I use this sometimes with my patients. It can also just be given to people to go through themselves, and then sort of use it as a gateway to accessing a whole bunch of other benefits. And I will tell you that the first iterations of this tool were developed with a group of health providers, a group of us. And then Prosper kind of took it off and developed it as a tool for social service agencies in general. It's in multiple languages, et cetera, et cetera. So really, really take a moment to look at the Benefits Wayfinder. All right, let's move to looking at what we can do as health teams, because this is kind of getting into I guess like just another level, I think, of what is possible in terms of addressing social risks to health. And through most of this, I really am going to focus in on what I have worked with my family health team to develop over the last, really, I'd say 12 to 15 years intensively. But this is just as to use us as kind of an example again of what is possible. I'll tell you, I mean, we're a very large academic family health team. We're in downtown east part of Toronto, St. Michael's Hospital academic family health team. We have about 50,000 rostered patients over 5 clinics. And this is a team that really over the last, again, about 12 to 15 years has progressively and sequentially built a focus on equity and on addressing social issues deeper and deeper into the core of who we understand ourselves to be, right? So much so that, I mean, our vision up here at the top left points to us wanting to be global leaders in the teaching, study, and practice of equity-driven primary healthcare and advocacy. We have a whole pillar of our strategic plan focused on equity and advocacy, and it's woven in really throughout. So, and I show you this not to kind of overwhelm you, but just to say that, you know, as this team got deeper and deeper into this work, it sort of wove its way deeper and deeper into the fabric of how we see ourselves and who we think we are. We actually, I mean, this is a few years ago now, we actually even produced a booklet that tried to tell a bit of the story of how we had developed this series of interventions. So, I mean, this booklet, it came out in 2019. We're just working on a refresh of it, which hopefully will be out early next year. But, you know, if you want to sort of see a little bit in a little more detail, not a lot of detail, it's mostly pictures, but it's a very easy read, and a little more detail, what I'm going to offer to you, you can just pull this up and take a look at this. So to sort of build out kind of what we've done on this front, I'm going to offer you a bunch. These are really a bunch of ideas, right? And this is, again, not to say that I expect that anyone will be able to just put this program in place in your settings, but I'm hoping that you can kind of pick and choose things that start to feel relevant to your practice setting, And, even in very small ways, start to think about how you might implement these sorts of approaches in your team as a group using the resources available to you. So we've built a couple of what I think of as really foundational pieces to our work, right? One of them is really around just kind of training our staff to approach their work through what I've called an equity lens, which means starting to think about what we do through an understanding of how our programs and services impact different groups and different people differently, and thinking about what corrections we need to make sure that we are being equitable in our approaches. There are tools we use to do this, like things called health equity impact assessments as examples, but a lot of this is just kind of discussion and starting to pull data out of our EMR and other systems, quality improvement work to try and see this. The other really foundational piece is around bringing the community voice deeply into the work that we do. So we've been developing a patient and family and community engagement strategy in our team for quite a long time now, as I think many teams are doing. But again, what's important to me is that we are actively working to bring forward the voices of people who come from groups that have been socially marginalized and get their critical perspective on the work that we are doing. And this is very foundational to being able to shift our practice towards addressing those needs fully. We've also developed a whole series of interventions that really focus on those kind of branches of the social determinants tree that I pointed to before, right? So the kind of hard material determinants of health that directly impact on the conditions in which people live. And these are some examples of that work specifically. And I'll show you a couple of these programs in just a moment. But these were all developed. In fact, all of these programs you see here were developed really over a couple of years. They were developed partly through Ministry of Health funding, partly through partnership funding, and a bit through research funding. So we really just had to kind of be creative in how we pulled this off. But I mean, they really just required champions, and in many cases, interdisciplinary champions who were excited to just try something new on the front lines of care. For example, we now have 2 full-time income security health promoters on our team. These are specialists in working with our patients directly around improving their income security. And I mean, the data that you see represented here briefly shows that this is a busy program, number one, and it's a program that really does seem to be having an impact on people's income, which is pretty important. We actually ran a randomized controlled trial in this program and still waiting for the results of that. We've also developed some really neat partnerships, especially with the legal aid community. We now have something called our Health Justice Project. It's actually right now just reached its 10-year birthday. But this is a partnership with Legal Aid Ontario clinics, where we actually have direct access to lawyers for our patients. In fact, they come on site to work with our patients. And again, they are a very, very busy program. This is slightly old data now. I think the numbers are even higher right now. And they deal with a huge range of legal issues relevant to the situations in which our patients face. And this has been a very beneficial partnership. In fact, we have a textbook coming out about health justice, this sort of intersection, I think next summer or fall. So watch for that and definitely order a copy. We also have a series of programs we put in place that deal with the roots of these issues, right? Those kind of structural determinants of health that I pointed to earlier. And again, I mentioned earlier that I think it's really important to keep these 2 levels of action in mind. And this has been really key to our program design thinking. And these include, for example, work on racism. So we've had an anti-racism, especially anti-Black and Indigenous racism, working group in place for about 7 years now. That's just done a lot of education and, again, critical reflective work. We've done some very specific work on Indigenous cultural safety in our practice through consultative work and partnership work with Indigenous organizations in our community. More recently, we're doing work on accessibility, so addressing ableism and the ability for people who are disabled to access our services in appropriate ways. And then we support our team in doing advocacy, right? So really kind of tying what they're seeing and the kind of structural systemic issues they're seeing on the front lines of care into advocacy for higher level change. And we do that through mentorship and support for our providers who kind of identify issues that they feel need to be spoken to. We also do that, interestingly, through a full departmental advocacy projects that we start every couple of years. And in fact, the Indigenous cultural safety work and the accessibility for all work both started through departmental advocacy projects. And again, this is just a way to continuously remind ourselves that we need to be engaged at multiple levels with these issues. So what I just described to you, again, really developed over about 10 or 12 years of kind of very exciting work that sort of brought out a lot of champions and a lot of great creative thinkers within our practice. But also over the last couple of years kind of led me and those I work with to thinking about what comes next, right? Like what do we want to put in place next in terms of doing this work? And I'm going to offer this just as kind of a last sort of rounding out of this story. Sorry, I'm just looking at the chat here. So Owen says, is there a one-pager available to provide those with a positive screen, for instance, that reminds them to do their tax return, resources to help them do so, provincial programs that may exist, or is each situation too unique? We did develop quite a few years ago a kind of handout brochure for patients on this with the Ontario College of Family Physicians, actually. The challenge there was keeping it up to date, right? I mean, this landscape changes quite rapidly. It's a very dynamic landscape. What I recommend is developing a simple resource list relevant to your area. So including, for example, community agencies and services that will help people with filing taxes, with financial security assessments, and then other social issues, housing assessments, et cetera. So having a few core resources to go to, and then referring people on to some of those online resources I mentioned, like 211, Your Legal Rights, and especially the Prosper Benefits Wayfinder tool. And I think that would make a very simple one-pager, the combination of those resources. But I do think it needs to be tailored to your community a little more specifically than what I can develop. I'm not sure if that's helpful, but I'd be happy to kind of discuss that in a little more detail afterwards. All right. Any other questions at this point? I'm just rounding out at this point with some of the stuff that I'm excited about. So just to give you a taste of kind of where we're going with all this. So feel free again just to jump in. So the last couple of minutes, again, I just want to kind of offer you some thoughts about sort of what we have felt needs to be done next in terms of building out our programs. And again, this is just to give you a sense of sort of how dynamic this territory is, right? And as we kind of laid this out, these are the types of areas that we really felt we needed to hone in on. So bringing in a bigger population health focus to what we're doing, enhancing our community leadership work, really kind of transforming the culture of our team even more deeply to center this type of work, and then looking in an even bigger way at sort of what we can do around system transformation. And to illustrate kind of how we're putting this in practice, I'm going to use our latest program, which is something called the SEED program. So Support, Equity, Engagement, and Dignity for Seniors. This is a program that's sometimes known as a social prescribing program. So it really is about uh, having workers that specifically do outreach to socially isolated older adults and work to connect them with community supports and community services and deal with their whole social picture and especially with their isolation. So this is something that's kind of spreading across the country, this idea of social prescribing, but we have a very particular approach in our program. So just to illustrate how we've sort of incorporated this latest thinking into this program, first of all, a population health focus. So we did a bit of work to pull out what we could from the health data for our community to figure out really what the needs are of older adults living in our community. And I'm just going to offer you a little taste of what's actually quite a broad body of data. For example, we looked at the low income rate amongst people over the age of 55. So we work really in this little area here, again, downtown East Toronto. These triangles are the locations of our clinics specifically. So you can see here that there is an incredible concentration of older adults living at low income in our neighborhoods. We also looked at the number of older adults living alone. And once again, we found that especially in particular neighborhoods that we work in, there's very, very high numbers of older adults who live alone. So isolation is a big concern. And then we looked at things, for example, like knowledge or people who do not have a working knowledge of English or French. Again, I'm just pulling out examples from the data. And we see here that there are certain pockets in our community that have a very high proportion, right? Not necessarily as high as some other parts of Toronto, but certainly something to think about in some of the neighborhoods that we work in specifically. So this is really helpful in thinking about how we design a new service like this for our community specifically. And so, for example, like when we created this program, we put in place criteria that said we're going to look at people who are 55 and over, who are low income, who are socially isolated, and who live in those specific neighborhoods within our catchment area that seem to be most impacted by these areas and really allowing us to kind of focus in. We also built in specific elements that would enhance community leadership and community empowerment in this work. And again, I'm not going to go into these in detail, but just to give you a taste of the way we think about this. So, for example, resource transfer, or what we call resource transfer, is really built into the design of the program, meaning that as much as possible, we try and use our resources to directly benefit community-based programs. So for example, for seniors who are experiencing food insecurity, we provide them access to a locally run cafe called the St. Jamestown Green Cafe to get meals, right? So we're kind of perpetuating a real cycle within the community. Also, community leadership, where we have a specific community advisory committee of older adults who fit the profile of this program, who I can tell you have offered a very deep and critical lens on what we're doing. We've also done a lot of work in terms of, again, building this perspective into the culture of our team as we've carried forward with this. And quite specifically, I mean, we are integrating brand new health team positions. We're working on changing the way that we or using our internal processes and shifting them to make sure that the new program fits in with those, and then doing a whole bunch of training, right? So we have training videos that we've put forward. For example, we do presentations and work directly with providers, et cetera. And in fact, we've represented some early learnings from this in a recent publication that you are welcome to look up in Healthcare Management Forum Journal. And then we've carried this forward finally into thinking about how will we use our learnings to actually transform the system that we're working in. And three big categories here that I think fall into this. So education, advocacy, and knowledge translation, really big, exciting areas to work in. But just as a taste, for example, so we've helped to develop an online course to train other teams in how to engage in social prescribing. We work with a national organization that's working to push social prescribing into healthcare systems across the country. And then we continue to work directly with coalitions, and especially community-based coalitions that are advocating for social change. So I'll leave you with this quote, which I think it's from Arundhati Roy, and I think is a really nice kind of framing. It provides a really nice frame for the way that we are approaching this work, and especially the kind of bigger level systemic work. She says, there's really no such thing as the voiceless. There are only the deliberately silenced or the preferably unheard. And this is exactly the kind of thinking that we're trying to build into this program, that we are working to counteract these systemic realities through the work we do at the front lines and then beyond. So I'll leave it there. There's the objectives. Hopefully we've touched on them at least somewhat. And there's my contact info, which you're welcome to use. And we have a couple minutes left for any thoughts or discussion. Yes, Naomi, please go ahead.
Hi, Dr. Block. Thank you so much for the presentation. My initial question I was going to ask you was, so a lot of our, I represent our nurse practitioner-led clinics here in the West Parry Sound area. And a lot of our locations are in rural, remote areas of our catchment. And so my initial question was around anything that we might be thinking of from a rural, remote lens specifically. But I think a lot of the things that you touched on are applicable. And so if there's anything from that perspective, rural, remote perspective, that would be helpful in addition to think about the things that you brought up. And we're also trying to engage our communities with community advisory committees at each of our clinic locations. And so are there any specific tools that you can recommend to really make good use of those committees?
Yeah, so I mean, really good question. So I'll say a couple things. So in terms of the rural remote story, I mean, again, I think a lot of what I've said is very applicable in any setting. So just to be clear, I mean, I think it's somewhat generalizable, although I think the types of issues that come out or the way that social deprivation expresses itself in rural remote areas certainly is different to some degree, right? Like we see more transportation challenges, for example, access to community services can be a huge issue, and access to health services, of course. And then like the way isolation expresses itself in rural remote areas, of course, can be very, very different. And sometimes in very scary ways, right? When people are really far out and very isolated. And so it requires a bit of a different design. But you know that better than I do, right? So
Yeah. No, I appreciate your insight. You hit three nails right on the head there. Yep.
Yeah. Well, I mean, and this is not a new conversation for me. I've always been concerned that this work needs to kind of be applicable, generalizable to other settings. I think that I would say, first of all, just that needs to be built into the specific design of what you offer in your settings and the type of supports you offer. I think that community advisory committees are a huge, huge gateway into thinking about how that is done. I mean, my recommendations there, I mean, if we had another hour, we could spend the whole hour on that because we've spent a lot of time and done a lot of learning about this and made a lot of mistakes in this. But I'd say, first of all, try and make sure those committees have people on them that are truly representative of people who are living in socially marginalized situations. Because often that's not the case in those committees. And it's those kind of voices from the margins that I think are most powerful when it comes to those committees. Second of all, make sure there's a real accountability, right? So that what comes out of those committees really can be shown to be impacting the shape of your work. right? And that there needs to be a sort of reporting back. I think the leadership of our teams needs to be very, very responsive to those committees. And the more you can build in representation from lived experience into decision-making structures, evaluative structures in your teams, the deeper that work will go and the more powerful it will be and more transformative. And it has been hugely transformative for me. And I'd say over 10 years, of the last 10 years, we've only gone deeper and deeper into wanting to build that critical voice into our work. So hopefully that's a start. I can
Yep.
certainly put you in touch with, we have an incredible community engagement specialist who co-leads a lot of this work with me, and I'd be happy to put you in touch with her as well.
Great. Thank you so much. That's excellent. How can I reach out to you directly, or do you have someone that I can connect with for that connection?
Yeah, just reach out to me, email me. Kathy
Perfect.
has my email. Yeah,
Excellent. Thanks so much.
no problem. Sorry to go not leave a lot of time for conversation. I can stick around for a few minutes if people have other thoughts.
Any other comments, questions from anybody? I'm not seeing any hands or unmuting, so. Thank you
Perfect.
so much for coming and presenting to our team today. You've certainly left us with a lot to mull over and some work to do, I think. So thank you.
My pleasure. Yeah, thanks for having me. And it's an ongoing conversation. So looking forward to seeing where this goes.
Perfect. Thank you so much.
Thanks, everyone.